Oh my god. Masa அப்படி வாங்கி connected. So shall I start? Well, can I start? Welcome students. I am Dr. Sarath Balaji on behalf of PW going to discuss about some important questions from pediatrics. Let us start the question number 1. What is this question? A 3-year-old child with the diarrhea for 2 days was irritable, extremely thirsty. What is the next step of management? This is the first question. What is the next step of management? So, what is this? The child is very irritable. The child is very irritable, extremely thirsty. How do you differentiate your dehydration? No, some, severe. So, what are all the classifications you have? No, some, severe. What are all the points you will see? Sensorium is normal. So, first one is normal sensorium. Eyes not sunken, tears present, and then tongue wet, thirst normal, skin pinch goes back immediately. Skin pinch goes back immediately. So this is no dehydration. What is the treatment for no dehydration? Nothing, just observation. ORS can be given. Whereas, what is that management for some dehydration? Let's see. So this is no dehydration. What is the management for some dehydration? For some dehydration, sensorium, the child will be irritable. 1. Eyes will be sunken. Tears, they are absent. Tongue will be dry. Thirst present. Very thirsty. Skin pinch goes back slowly. Goes back slowly means less than 2 seconds. What is the management of choice? ORS 70 ml per kg over 4 hours. Over 4 hours. This is for some dehydration. What is the management for severe dehydration? Let us see. What is the management for severe dehydration? For severe dehydration, the child will be dull looking. Eyes very sunken. Tears absent. Tongue dry. Thirst cannot drink. Thirst will be present but the child cannot drink. Skin pinch goes very slowly. That means takes more than 2 seconds. What is the management of choice? Oral with 5D or normal saline. How much you need to give? 100 ml per kg. How do you give? Less than 1 year, more than 1 year to 5 year. Less than 1 year, 30 ml per kg, and then 70 ml per kg. Less than 1 year, 30 ml per kg over 1 hour, 70 ml per kg over 5 hours. So totally 6 hours. Whereas 1 to 5 years, less than 30 ml per kg, less than 1 to 5 years, 30 ml per kg over half an hour and 70 ml per kg over 2.5 hours. So it covers a duration of 3 hours. So 6 hours in case of children less than 1 year, 3 hours in case of children between 1 to 5 years. What is the IV fluid of choice? The IV fluid of choice is your RL. So IV ringer lactate is the choice. So for question number 1, IV ringer lactate is the treatment of choice. And what is the age of the child? Is 3-year-old. So what is the assessment? Irritable, extremely thirsty. Right. So let's go to the next question. Identify the abnormality in the following X-ray with newborn distress. One second. Okay. What are all the neonatal conditions that can present with what are all the neonatal conditions, surgical conditions that can present with respiratory distress? Okay. When you see loosened areas in the lung, when you see loosened areas in lung without diaphragm, without diaphragm, it is congenital diaphragmatic hernia. What is tracheoesophageal fistula? When you have coiling of tube in neck, it is tracheoesophageal fistula. Hiatus hernia less likely to be asked. Less likely to be asked. And what is 𝐒𝐿 when you have a mass lesion, radiolucent lesion, that is, I can say, black lesion with, it can either push the mediastinum, that is your heart, or trachea. If it is in the lower lobe means it will push the heart to the opposite side. If it is in the upper lung means upper part, upper zone means it will push the trachea. So the common surgical conditions that are associated with the respiratory distress are H-type fistula, look for the coiling of the tube. Second one is cystic lung spaces with mass effect, usually a single cyst. It usually presents with persistent pneumonia or complicated pneumothorax. And the last one is multiple loosened areas in the lung, and you can't see any proper diaphragm junction in between thorax and chest. Let me show all those uh, pictures at the end of the session. So look for these three things to identify respiratory distress in newborn. A loosened lesion, a single loosened lesion in the lung causing mediastinal shift, that is your congenital cystic adenomatoid malformation. Group of cystic lesions in the lung, that is your, what is that, congenital diaphragmatic hernia. And you have coiling of tube, otherwise known as H-type fistula, right? Then let's go for the next question. Which of the following statement is true? First, hand to hand transfer appears, then palmar reflex disappears. Second, fast palmar reflex disappears, then hand to hand transfer appears. Both palmar reflex and hand to hand, both palmar reflex and hand to hand transfer appears at the same time. Both disappears at the same time. So how to find out the answer for this question? Very simple. What is palmar reflex? So one, we have palmar reflex. Or else I can say palmar grasp and plantar grasp. So usually it appears by, so when you stroke this pen in a newborn over hypothenar eminence, it will gradually grasp the pen. This is called palmar reflex. It usually appears by 28 to 37 weeks. You give anything, it will, you give anything, it will grasp. That is You just touch, it will grasp. So gradually this will disappear by 6 months. So the child can release objects. The child can release objects that it is holding. When it release, it can transfer the object by 6 months. So palmar grasp or reflex appears by about 28 to 37 weeks. It gradually fades out, disappears by 5 to 6 months, so that your transfer of object can appear at 6 months. So what is the answer? Palmar grasp reflex disappears so that the hand transfer appear. Answer for this question is B. Answer for this question is B. Then let's go to the third question. What is this? A child presents with generalized weakness and his hemoglobin was low and serum iron was low. Which of the following vitamins help in iron absorption? Let us see one by one. Vitamin C. What is the role of vitamin C? The role of vitamin C is to strengthen your collagen. By what? By hydroxyproline formation. Hydroxyproline formation. As a result of which it aids in wound healing. It aids in wound healing and it will reduces your bleeding. When your vitamin C nowadays usually occurs in autistic children. Usually occurs in autistic children. What will happen? It will lead to delay in wound healing. Delay in wound healing. Hemorrhage because of the poor collagen vascular support. Fragility of blood vessel. Fragility of blood vessel. Fragility of blood vessels. So it can lead to cerebral hemorrhage. It can lead to hemopericardium. Can lead to hemopericardium and painful scorbutic rosary. Painful scorbutic rosary. Scorbutic rosary. So what is the treatment? 100 ml orange juice. Orange juice per day. Apart from this, what are all the other functions of your vitamin C? It reduces ferrous to ferric so that it will be absorbed easily in the stomach, and also it causes antioxidant, protects antioxidant effect on vitamin E and folic acid. Vitamin E and folic acid. Okay, vitamin E and folic acid. What are all the other effects of vitamin E and folic acid? Apart from that, what is the other role? You can say the other things are. Let me complete this. So what is this? What is this? You have pencil thin cortex. You have pencil thin cortex followed by what will happen? What will happen? Pencil thin cortex, then a rare feed, tremor filled rare feed zone. What is this zone called? Tremor filled zone in the metaphysis. And then you have small projections from the metaphysis called as Pilken spur. Called as Pilken spur. And finally, what is this? Round epiphysis, otherwise known as Wimberger sign. Round epiphysis, otherwise known as Wimberger sign. So these are all the four pathological features of bone in vitamin C deficiency. Right. Then comes what are all the effects of B12? What are all this? So this is one. Then what are all the effects of B12 deficiency? So let us finish. Very, very important. What are all the effects of B12 deficiency? B12 deficiency is characterized by megaloblastic anemia. Characterized by megaloblastic anemia and macrocytic anemia. So megaloblastic means what? More than 100 femtoliters. Macrocytic means more than 100 femtoliters. Megaloblastic means more than 5 segments in neutrophil. Neutrophil. Otherwise known as hypersegmented neutrophils. Apart from that, what else a B12 deficiency can cause? Okay, knuckle hyperpigmentation. Can cause knuckle hyperpigmentation. And then it also causes knuckle hyperpigmentation. What else it will cause? Infantile tremors. What else will cause? Infantile tremor syndrome and pancytopenia. And then also neuroregression. Neuroregression. So what is the investigation of choice? Urine methylmalonic acid. Increased urine methylmalonic acid. So we had finished B12 and then vitamin A. So what are all the points for vitamin A? Let's see. What are all the points for vitamin A? So vitamin A deficiency is characterized by, you all know, white dot spots, conjunctival cirrhosis, corneal cirrhosis, corneal ulcer, xerophthalmia. Xerophthalmia. So what is the management of this corneal ulcer? It is very, very an emergency situation in which you will be requiring water soluble vitamin A. Water soluble vitamin A. Okay, IM. Emergency management. For white spot conjunctival cirrhosis, that can be tackled by giving 2 lakh international units on day 1, 2 lakh international units on day 2, and 2 lakh international units on day 14. This is the prophylactic therapy used in national schedule. And finally, vitamin E. Vitamin E. Can anyone tell me what is the management, what is the manifestations of vitamin E? The vitamin E usually manifest with vitamin E. So now vitamin E, it causes hemolysis in preterm. It causes hemolysis in preterm. Hemolysis in preterm, ataxia in older children. All cases of ataxia should be evaluated for vitamin E deficiency. Ataxia. So causes pancreatic insufficiency such as cystic fibrosis, okay, any malabsorption Also, you can find in A beta lipoprotein. A beta lipoproteinemia. A beta lipoproteinemia. So these are all the questions that can be asked with respect to this question. But what is the role of vitamin C? Apart from that, vitamin C reduces iron ferric to ferrous. So it aids in the absorption of iron as well as hemoglobin. So the answer for this question is probably vitamin C. Okay. What are all the vitamin? Right. Okay. Now, next question. A boy presents with shock and cold clammy. The next step in management is very simple. So now the child is having shock and cold clammy. How to approach? So the first thing that you need to do in case of any shock. So shock means you need to give 20 ml per kg of normal saline over 20 minutes. Over 20. Then if the child is still not responding, you need to give whether it is a warm shock or whether it is a cold shock. Warm shock means you need to give adrenaline. Cold shock means you need to give noradrenaline. Still, if the child doesn't respond, means it is called catecholamine resistance. Catecholamine resistance, for which you can consider other drugs such as mildrenone, etc., or other inotropes such as dopamine. At any point of time, the best management of shock is 10 ml per kg of normal saline bolus. I repeat, 10 to 20 ml of normal saline bolus. And one more new point I want to register. What is that? Not more than 40 ml per kg. Not more than 40 ml per kg. The maximum allowable bolus of normal saline in case of shock is 40 ml per kg only. Okay, only. Right. Next question. Mutation in which of the gene is seen in Wilson's disease? Is seen in Wilson's disease. ATP 7A or 7. 7A is associated with Menkes disease. 7A is associated with Menkes disease. 7B is associated with Wilson disease. Okay, now let us discuss about some important questions in Wilson. Some important questions in Wilson. Right. So what are all the questions? What will be the manifestation of Wilson disease? It can present as asymptomatic hepatomegaly. It can present as acute hepatitis. It can present as chronic hepatitis. It can present as hepatosplenomegaly with portal hypertension. It can also present as cirrhosis. But Harrison says that no neonatal or cholestatic picture. Okay, cholestatic picture. So this is with respect to liver. Gastroenterologist, whenever they see any case of liver involved, they will usually rule out Wilson's disease. So point number one. Second point. The second point is they can cause this copper direct damage to RBC, leading on to hemolysis, leading on to hemolysis. So Coombs negative hemolytic negative 3. It can cause chorioathetosis by involving copper causing damage to basal ganglia. And finally, 4. It can cause neuroregression in school going, which one? Wilson's disease. So whenever you come across these presentation, the first thing you need to rule out is you need to do is serum ceruloplasmin. If it is less than 20 milligram per deciliter, or you can use a liver copper of more than 250 microgram per gram of dry weight of, or rarely nowadays they use urine copper 24 hours more than 100 milligram per after penicillamine or chelator. So what is the treatment of choice? The treatment of choice is, so the treatment of choice for Wilson's disease is very simple. Chelators are penicillamine as well as trientine. Trientine will not have any side effects, whereas penicillamine will produce skin rashes, SLE like. Next, you have ammonium tetrathiomolybdate. Ammonium tetrathiomolybdate. Then you have your zinc. These two are chelators. Trientine is preferred over penicillamine. Ammonium tetrathiomolybdate, Wilson. Zinc. Where will you use zinc? Zinc is for asymptomatic carrier, particularly because starts the absorption of 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 so this is with respect to your Wilson's disease ATP7A. I'm sorry, ATP7B. So what is ATP7A? Menkes disease. So Menkes disease. Menkes 1. ATP7B. The manifestations are hair abnormalities, 𝐒𝐿𝐾𝐄, along with neuroregression. They are prone for hypothermia. It preferentially involves your gray matter without photospleomegaly. Menkes hair disease. Hair is the characteristic feature of 𝐒𝐿𝐾𝐄 hair disease. You can get HS. It is a neuroregressive disorder that should be suspected whenever you see any case of along with neuroregression along with hair abnormal. Right. Then comes, so this question is over. Then the condition seen in this child could be due to which of the following? So look at this child. The child is having protuberant abdomen. What is this? You all know. So kwashiorkor, marasmus, we are going to deal. Let us have a small discussion on kwashiorkor and marasmus. First, let us discuss about kwashiorkor. Kwashiorkor. Kwashiorkor is mainly due to protein loss. Mainly due to protein loss. As a result of which you will get bilateral pedal edema, mental apathy, bilateral pedal edema, mental apathy, hepatomegaly, and it has got poor prognosis, more prone for infection, more prone for delayed recovery. Along with that, because of skin involvement, flaky paint dermatosis, as well as burns scar like skin. Paint dermatosis and burns scar like skin. Whereas marasmus is characterized by calorie loss. And the main characteristic feature of marasmus is wasting of subcutaneous fat, leading to monkey faces. Monkey faces means loss of subcutaneous fat in the cheek. Baggy pant appearance. Loss of fat in the buttocks. Finally, it will involve hands too. Monkey paint appearance and baggy pant appearance. But it is mainly calorie and it more common less than 1 year. Whereas kwashiorkor is more common between 1 to 5 years. So appetite will be good. So recovery will be fast. This is marasmus. Less prone for. This is for marasmus. The other name for kwashiorkor because of edema is sugar baby. Is that? Is sugar. So kwashiorkor is due to less protein and more calorie. Wrong. Kwashiorkor is due to less calorie intake. Wrong. Marasmus is due to less protein. No, and calorie. Only calorie. Marasmus with low calorie intake. So answer D is correct. And one more point. What is the definition for severe acute malnutrition? Severe acute malnutrition. Definition. weight for height less than 3 standard deviation. Second, mid upper arm circumference less than 7.5 centimeter, bilateral pedal edema, and finally visible wasting. This is for severe acute malnutrition. Right. A 4-year-old child brought to the emergency following a sudden fall at school. His pH was 7. His pH was 7.2. So pH 7.2 means is acidose. It can be respiratory or it can be metabolic. Respiratory is characterized by high PaC. Normal is 35 to a PaCO2 of more than 45. Okay, kPa kilopascal is respiratory acidosis, mainly due to what? Respiratory failure. Whereas metabolic means reduced bicarbonate. Bicarbonate, it will be less than 14 millimole per liter. It can be either high anion gap or normal anion gap. Normal anion gap is renal tubular acidosis. Here 7.2, PCO2 is 64. So this is a case of respiratory failure. Bicarbonate is normal. PO2 is somewhere around 65 to 100. Hypoxia is there, but compared to that, hypercapnia is there. So this is a case of respiratory failure. Respiratory acidosis because pH is less than 7.2, and PCO2 instead of being between 35 to 45, it is more than 64. So this is a case of respiratory failure. Which drug is preferred in premature neonates for closure of PDA? So, what are all the things you need to know in patent ductus artery? Let me finish a small bird's eye view on congenital heart disease. Congenital heart disease. So congenital heart disease is divided into acyanotic and then cyanotic congenital, acyanotic and cyanotic congenital heart disease. Acyanotic will be divided into left to right at the level of atrium, at the level of ventricle, at the level of great artery. So your AST, EST. Whereas obstructive lesions. What are all the obstructive lesions? Critical aortic stenosis. What are all the obstructive lesions? Critical aortic stenosis, coarctation of aorta. These two are obstructive lesion. Obstructive lesion. What is the presentation of obstructive lesions? Okay, then cyanotic will be divided in with increased pulmonary blood flow, otherwise known as pulmonary plethora. Example, pulmonary plethora. Example, your total anomalous pulmonary venous connection. your transposition of great arteries, your truncus arteriosus. Whereas with reduced pulmonary blood flow, otherwise known as oligemia, what are all the differential diagnosis? Metrology of Fallot, pulmonary atresia, Epstein's anomaly, and finally tricuspid, Epstein's anomaly and tricuspid atresia. So what will be the manifestation of the disease? What will be the manifest? So either it is a blue baby, one second. Either you can have a blue baby. Blue baby means what? Sinus. Means sinus. This blue baby, if associated with the heart failure or cardiomegaly, it is usually transposition of great arteries, total anomalous pulmonary venous. If it is associated with normal heart size, means no cardiomegaly, means cardio. So it is pulmonary oligemia, as we saw TOF, tricuspid atresia, pulmonary atresia. The presentation is the only blue baby. This is only blue baby. This is blue baby with CCF. Blue baby with blue baby. Second is pink. Second is what? Pink. Okay. That is with, if it is left to right shunt, can present as recurrent pneumonia, can present as murmur, it can present as congestive cardiac failure, or it can present as Eisenmenger syndrome. That is, your left to right shunt become right to left shunt. Okay, and then obstructive lesion. That is your coarctation of aorta, critical aortic stenosis. They often present with shock. By about 4 weeks of life, large AST, VST, PDA life, when pulmonary arterial pressure decreases. And finally, let's come to our PDA, our patent ductus. You all know it often presents with continuous murmur. It is a pansystolic murmur heard in the left infraclavicular area, and it is a machinery murmur. The presentation is dancing carotids, with all signs of aortic regurgitation. So this patent ductus arteriosus should be Diagnosed in cases where all findings of aortic regurgitation is present, that is your Corrigan pulse, Demuson signs, etc. What is the treatment for PDA? So small PDA, preterm PDA, or you can close with oldest therapy is Indo method, oldest method. And then when I was doing postgraduate, Brufen. And finally, right now, paracetamol infusion is the treatment of choice for PDA. So the answer for this one is paracetamol or patent ductus arterius. And one more point that you need to know in patent ductus arteriosus is PDA is PDA plus Eisenmenger syndrome. What will happen here? You will get differential sinosis. Upper limb SpO2 will be high. Lower limb SpO2 is upper limb is differential sinosis. So what is differential sinosis? Differential sinosis is upper limb SpO2 will be high, whereas lower lobe SpO2 will be low. This is called differential sinosis. So we had a bird's eye view on cardiology. What is this? Two open vials of pentavalent vaccine and one open vial of MMR vaccine is given back after an immunization. What should be done with those vials? Right. Let us see about these vaccines. Let us finish vaccine schedule indeed. Now, with this, let us finish. So, at birth, BC, OPV, hepatitis, at birth, at 6 weeks, so 6 weeks. What are all the vaccines that are given at 6th week and 14th week? They are one and the same. Pentavalent, intramuscular thigh. Then pentavalents contain diphtheria, pertussis, tetanus, hepatitis B. Hepatitis pentavalent second. So it contains the first one. Second is rotavirus, otherwise known as rotacil. And then you have intradermal IP, at 6 and 14 weeks. Along with that, these are all common. Along with that, you will receive PCV13 one dose, along with PCV13 one dose at 6th week, PCV13 second dose at 6th week, again IPV dose 1 first week, IPV dose 2 is at 14th week. So what are all the vaccines that are given at 10th week? What are all the vaccines that are given at 10th week? 10th week, pentavalent, rotacil, okay, pentavalent vaccine, rotacil, and no IPV, no PCV13. Which one? 10th week. So 6, 10 and 14 are one and the same. 9th month. MR1, measles rubella 1. Okay, vitamin A. Vitamin A. JE, Japanese encephalitis 1. 9th month. Then OPV, sorry. You have pneumococcal vaccine, PCV. Okay. So pneumococcal conjugate vaccine will be given at 9th month. Also fractionated IP. At 15th month, at 15th month, MR2, JE2, MR2, JE2, DPT booster, then OP. 15th. And then at 18th month, pentavalent, not so 18th month, what you will put? 18th month. So 15 months. So that's all. 15 to 18 months, these vaccines. At 5 years, DPT. At 10 years and at 15 years, DPT. And at 10 years and 15 years, it is TD. Is not capital T, capital D. Is capital T, small d. Reduced doses of diphtheria. Diphtheria. Okay, this is all about vaccination schedule in India. All about vaccination schedule in India. So what is this? What is the most probable diagnosis? What is the probable diagnosis in this child with the bull neck? What is the probable diagnosis in this child with the bull neck? Let's see. So bullness is caused by diphtheria. Bullness is caused by diphtheria. Okay, bull neck is caused by diphtheria. Point number 1. Okay, you all know that bull neck, otherwise it is called by Corynebacterium diphtheria. Diphtheria, it is a gram positive organ. It is a gram positive organ. Which one? Corynebacterium diphtheria. So what is the manifestation? You have nasal, okay, nasopharyngeal, laryngeal, laryngeal. Okay. So this often presents with discharge. Nasopharyngeal will have membranous tonsil. Laryngeal is equal to stridor. Stridor. Corynebacterium diphtheria. Laryngeal usually leads to stridor. Cider. These are all, and then you can have, what are all the associated things? You can have arrhythmias at second week of illness, arrhythmias, second week of illness, whereas again second to third week, it can also cause descending paralysis. It can also cause descending paralysis, loss of accommodation, loss of accommodation, loss of oculomotor, bull neck. So what is the treatment of choice to prevent spread? Erythromycin. Recurrent, okay, erythromycin, it prevents spread, whereas treatment is immunoglobulin, but you can have AT. Okay, you have antitoxin. You have antitoxin, usually 50,000 to 1 lakh. 1 lakh. What is that? Anti. Okay, so immunoglobulin, one which prevent the spread is erythromycin, and you need to give antitoxin is the management of anti. A 7-year-old girl presented with thumb sign on X-ray. Which organism is most commonly responsible for this finding? One, thumb sign. Okay, right. So this is all about bull neck caused by Corynebacterium diphtheria. A 7-year-old child presented with thumb sign on X-ray. Which organism is responsible? Commonly, you need to know two important. One is acute laryngotracheobronchitis, otherwise known as croup. Second one is epiglottis. Epiglottis. ALTB, usually coryza will be there, significant cough will be there, followed by cider. What is the management of choice? Dexa or steroids in any form. Dexa. It reduces the severity, and then adrenaline nebulization. Commonest cause is para-influenza. Whereas epiglottitis previously caused by epiglottitis what is the sign in case of ALTB? ALTB, you will have steeple sign. Epiglottitis. In ALTB, cough will be predominant, no toxicity. Group. Whereas epiglottitis is characterized by high-grade fever, okay. So epiglottitis is characterized by toxic high-grade fever, odinophagia, okay, fever, okay, odinophagia, and then you can have what? What is that sign called as? Thumb sign. What? Thumb sign. Presentation is odinophagia with restriction of neck movements. Okay, odinophagia with the restriction of neck movements. X-ray you will have thumb sign. Treatment of choice is zone. But before that, if the child is sick, you need to go for intubation. So this is the difference between ALTB-R group and epiglottic. What is the first sign to appear in a child? What is the first tooth appear in a child? So temporary, permanent. So temporary tooth, lower central incisor, lower central incisor. Okay, first tooth, lower central incisor. Okay, what else? Lower central incisor. Last tooth is last molar. First tooth in permanent is molar. Last one is molar is the first to appearance in temporary teeth and gradually completed over 12 to 13 years. This is all about first two tooth appearance. Okay. A pregnant lady with mood disorder was on lithium issues. The baby born through her previous pregnancy A pregnant lady with a mood disorder mother was on lithium. 1 second. Okay. A pregnant lady with a mood disorder mother was on lithium for her psychiatric issue. The baby born through her previous pregnancy has Down syndrome. This child can be born with which of the following? So here lithium. Lithium, we all know that it is associated with Epstein's lithium. So let us cover some of the features of Epstein's anom. So what are all the features of Epstein's anom? Huge heart, massive cardiomegaly, variable sinosis, variable and okay, large heart, massive cardiomegaly, variable sinosis, variable presentation, variable presentation. It can present in any part of the large heart. Okay, variable sinosis, presentation, variable sinosis. It can present with any kind of its presentation. Large heart, variable sinosis can present at any age. Any age. Present at any age. Epstein's anomaly. Variables and then multiple hearts. Multiple heart sounds. Large heart, variable sinosis, presentation at any age, multiple heart sounds can be associated with what is that? It can be associated with first degree heart. associated, it can be associated with raw. Okay, multiple heart sounds. Large heart variable cyanosis presentation at any age, multiple heart sounds. And it is characterized by massive cardiomegaly. It is prone for Wolff Parkinson White syndrome. It is prone for Wolff Parkinson's White syndrome. H1 Epstein's anomaly. Okay, then a child with hypoglycemia was found to have burnt sugar urine odor. Which enzyme is deficient? Which enzyme is deficient? Let's see. Which enzyme is deficient? Very, very easy. A child with hypoglycemia. So you have a case of hypoglycemia, burnt sugar urine. How to approach? Approach to neonatal hypoglycemia. A blood glucose of less than 45 milligram is high. So whenever you have hypoglycemia, the first thing you need to see ketone bodies. If ketone bodies are absent, it can be due to high insulin, can be due to acidoblastosis, okay, fatty acid oxidation. These are associated with absent ketone. When ketone bodies are present, then it can be due to, you divide into two. Okay, with hepatomegaly. In with hepatomegaly, lactic acid present. So lactic acid plus means 𝐒𝐿𝐻𝐿𝐃 disease. Lactic acid absent means it can be ori or and. And then you have without hepatomegaly. Ketone bodies without hepatomegaly can be due to pituitary insufficiency. This is approach to hypoglycemia. Now we have a child with hypoglycemia, burnt sugar urine. So urine odor we need. Urine. So what are all the urine odor you know? How you have burnt sugar urine. You have tea odor. Okay. Burnt sugar, tea odor. Then what else you have? Rotten. Rotten cabbage is musty odor, phenyl ketone, burnt sugar, maple syrup, even 𝐒𝐿 multiple carboxylase deficient. Based on this urine odor, we can classify. What else you can have? So the answer for this question is branched branched chain alpha keto acid dehydrogenase. Branched chain alpha keto acid dehydrogenase. Maple syrup urine disease. Remember, for this disease, thiamine can be given. Thiamine given. Let me have a small session on the vitamins in role of vitamins in which one? Inborn errors of metabolism. So what are all the inborn errors of metabolism? Vitamins B1, thiamine, B2, riboflavin, pantothenol, B6, pyridoxine, B6, thiamine, riboflavin, pantothenol, B7, biode, B7, biode, B2, cobalamin. Thiamine is used in maple syrup urine disease. Riboflavin is angular. Pantothenic acid is associated with burning feet. Pyridoxine associated with is can be used in homocystinuria. Biotin is used in multiple carboxylase. B12 cobalamin is used in methylmalonic acid. Then tetrahydrobioptenyl ketonuria. Tetrahydrobioptenyl. Then betaine used in substrate reduction, mainly reduction therapy. These are all the things about. Then what else? Nitisinone. Nitisinone is used in alkaptonuria. This is all about vitamins in eye. Which enzyme is deficient in Lesch-Nyhan syndrome? Hypoxanthine guanine phosphoribosyl transferase. What is this Lesch-Nyhan syndrome? It is characterized by elevated uric acid. Self-injurious behavior. Also can present as chorioathetosis. Which one? Lesch-Nyhan syndrome, and it is X-linked. Whereas biotinase is associated with multiple carboxylase deficient. And one more point for biotin is, okay, boil the egg to have boil the okay, biotinase deficiency multiple carboxylase deficiency, which can be manifested as alopecia with neurorecurrence. One, which one? Biotinase deficient. Right. Now the next question is a 2-year-old girl presents with recurrent episodes of early morning lethargy and seizures. On examination, the child had doll-like feces and hepatomegaly. So it is 𝐌𝐞𝐝 disease. Which investigations will hypoglycemia, lactic acidosis, hyperlipidemia? Which enzyme is deficient? Glucose 6 phosphate. Which enzyme? Glucose 6 phosphate. So 𝐌𝐞𝐝 disease is characterized by, one second. Okay, so what is the manifestation of 𝐌𝐞𝐝 disease? So it is type 1 glycogen storage disease. It is characterized by glucose 6. It is characterized by hepatomegaly, recurrent hypoglycemia, hypoglycemia along with elevated lactic acid, elevated uric acid, elevated lactic acid, elevated uric acid, and elevated triglycerides. What is the treatment for type 1 glycogen storage disorder? The treatment for type 1 glycogen storage disorder is avoid glucose, galactose, fructose. How will you find this one? Avoid all this. Okay, avoid glucose, galactose, fructose. Give overnight constant. Overnight. So that it will be slowly receiving blood, slowly receiving the glucose into blood. A 3-year-old child. Next question. A 3-year-old child with recurrent episodes of diarrhea and abdominal distension. On examination, he was found to have anemia, short stature, and failure to thrive. An upper GI endoscopy along with the duodenal biopsy revealed villus atrophy. What is the probable diagnosis? Very simple. Celiac disease. So when will you find celiac disease? Okay, recurrent blue stools, okay, malabsorption leading to weight loss. and then because of that the child will be shot. Gliadin causes damage to duodenum. Gliadin causes damage to duodenum. Okay, so iron is not not celiac disease. Investigation of TTG tissue transcriptase should be 10 times the normal. Second one is anti-endomysial antibody. Anti-endomysial antibody. Okay, this is specific. Okay, tissue transglutaminase anti-endomysial antibody. Okay, now you can have two options. Is invasive. Invasive is go for biopsy to look for short villus. Okay, it is okay. And a biopsy, invasive biopsy to look for total villus atrophy. Total atrophy. Another non-invasive test is HLA type. HLA B27. Okay, will often be isolated. Treatment. Wheat, corn, rye. All should be avoided. Rice is safer. Okay, rice is safer. This is all about celiac. What is this? A 14-year-old boy found to have hypogonadism. On investigation, this child was found to have, sorry, little bit hungry, high levels of LH, FSH and testosterone. Which of the following enzyme could be deficient in this child? Let us solve this problem. I so when you have LH, FSH level in hypogonadism, you have high, you have high, or LH, FSH can be low. Can be high LH, FSH means testosterone is LSFHS low means central. Okay. High LHFSH means example Klinefelter. Low LHFSH is testosterone defect. Low LHFSH means central. Example Kalman syndrome. So what happens here? In 21 alpha hydroxylase, congenital adrenal hyperplasia. 21 alpha hydroxylase is congenital adrenal hyperplasia. 11 beta hydroxylase is also congenital adrenal hyperplasia. So in congenital adrenal hyperplasia, 21 alpha and 11 beta are associated with precocious puberty in boys. Is associated with precocious puberty in boys. Okay, 21 alpha hydroxylase and 11 beta hydroxylase precocious puberty. In 21 alpha hydroxylase, hypotension. in 11 beta hydroxylase hypertension. So here 5 with hypogonadism. So cannot be 21 alpha, cannot be 11 beta. Then what else? So it can be either 5 alpha reductase or 17 alpha hydroxylase. So now is a boy with hypogonadism with elevated LH. So if it is high, expect high mark. Okay. So by if hypoglycemia, LSFSH high means what will happen? Something below is not working. It can be due to 1720 lyase, 17 alpha hydroxylase deficiency, 3 beta HST deficiency, 3 beta hydroxysteroid dehydrogenase deficiency, 1720 lyase, 17 alpha, okay, and then 3 beta HST, and then 5 alpha reductase deficiency. Here testosterone is converted into dihydrotestosterone, 5 alpha. If 5 alpha is not present, testosterone will be high. So the answer for this question is probably 5 alpha reductase deficient. Most common cause for inspiratory stridor stridor in newborn. So most common cause laryngomalacia. Most common. Second most common vector. Okay. So laryngomalacia is the most common cause for stridor, followed by Albright's palsy, followed by subglottic stenosis. These are all the 3 important causes for stridor in new. Child oral vitamin A dosage in a 2-year-old malnourished child weighing 8 kgs. Oral vitamin A dosage in a 2-year-old malnourished child, 2-year-old 8 kgs. Vitamin A less than 6 months, 6 months to 1 year, more than 1. Less than 6 months, 50,000 international. 1 lakh, 6 months to 1 year, 1 lakh international. More than okay, 1 lakh. More than 1 year, 2 lakh international units. So this is a 2-year-old child, means I need to give 2 lakh international. Vitamin K is given at birth to prevent which of the following? Very, very simple. Vitamin K given at birth to prevent which of the following? So hemorrhagic disease of newborn, early, classic, later, later. So early means day 1. It is due to drugs like maternal anticonvulsants. Early. Classic means 2 day to 2 weeks. It is mainly due to what? Absence of giving. Okay. So early HTN in the same day. Classic HTN 2 weeks to 2 months. Late onset HTN any days. Any hemorrhagic disease of newborn. So you need to give vitamin K for all newborn. Vitamin K. Okay. What is called PUCA? It is called PUCA. So what will happen whenever vitamin K is absent? Your LFT will increase. Okay. Whenever you have vitamin K deficiency, what will happen? In vitamin K deficiency, factor 2, 7, 9, 10. This will lead to prothrombin, increase partial thromboplastin. So when someone uses FFP, this PT, KPTT, they will become normal when you give FFP. So how to find out in a child who had received FFP after birth? Very simple. You need to use something called PUCA. That is protein induced in vitamin K absent. PUCA means what? Protein induced in vitamin K. PUCA. Infant of diabetic mother is at risk of the development of the following. What are all the things that can occur in infant of diabetic mother? Very simple. Hypoglycemia. Hypocalcemia. Polycythemia. Hypoglycemia, hypocalcemia, polycythemia. Fracture humerus. Shoulder dystocia. Shoulder dystocia. Tricuspid atresia. Most common cyanotic congenital heart disease is tricuspid. Most specific congenital heart. Okay, asymmetrical septal hypertrophy. Okay, most common acyanotic congenital heart disease. But usually it presents before term or taken towards date to assess. Okay, right. Most common congenital heart disease tricuspid atresia. Most common acyanotic congenital heart disease VST. Most specific congenital heart disease is asymmetrical septal hypertrophy. Okay, which one? Infant of diabetic mother. What else? Delayed umbilical passage. This delayed meconium passage in colon is due to lazy left colon syndrome. What else apart from that? Okay, sacral agenesis. Sacral agenesis. What else? That's all. This is all about hemorrhagic disease of. Okay. A 5-year-old child has absent seizure. Which of the following drugs would you like to give to the treatment? Valproate and lamotrigine are presently the correct drugs. Valproate and lamotrigine for absent. Which of the following is an absolute contraindication of breastfeeding is galactosemia. Galactosemia is an absolute condition to breastfeed. Okay, what is the difference between colostrum? Colostrum is first 2 days is colostrum will be thick, will be okay. It contains more galactose, more fat, okay, contains more proteins, contains more, contains more proteins, more immunoglobulin. Okay, so colostrum thick yellow, more protein, less, okay, less carbohydrate, and then colostrum. So colostrum is thick yellow, immunoglobulins are high. It contains high amino acid and minerals, but not high sugar and fat. Is characteristic of high sugar and fat is characteristic of what? What? Cow milk. Once oral vitamin in a 2-year-old malnourished child. 2-year-old means 2 lakh. Very easy. Fat sugar baby appearance. Kwashiorkor. Kwashiorkor sugar baby. Marasmus fat. Curvy winter bronchitis. D1 deficiency maple syrup urine maple syrup urine. Okay. A child was malnourished. Subcutaneous fat was not there. The skin was wrinkled and muscle wasting were there. Again, it is mainly a energy deficiency or calorie deficiency, so that the muscles are utilized for the production of energy, which should not happen in the body, which can lead to wastage of muscles. Menkes disease, copper deficiency, copper ceruloplasmin deficiency, copper X. Okay, now a 8-year-old child presented with hepatomegaly and hypoglycemia. He was diagnosed with the glucose 6 phosphate deficiency. So the following glucose 6 phosphate will be accumulated in the a child presented with the boil on 2 weeks with is now presenting a cutter. So what is the case of post-streptococcal glomerulonephritis? Post-streptococcal glomerulonephritis. So usually in post-streptococcal nephritis, you have hematuria. Should last for less than 6 weeks. Proteinuria should be less than 6 months. Okay, C3 becomes normal by about C3 should be normal. Image of slapped cheek appearance, erythema infectiosa. Okay, or otherwise known as parvovirus B. Parvovirus B. Right, image of slapped cheek, parvovirus B19. Right. It has peculiar propensity for pronormoblast. So it can cause aplastic anemia or pure red cell. Pure red cell aplasia, and it can also cause neuropathy in older children. Neuro. A child presented with a rash on limbs, hematuria, and jointing. There was a history of respiratory infection 1 week back. What is the probable diagnosis? P or palpable plus one of the following: D, A, D. Diffuse abdominal pain, diffuse abdominal pain. A for IgA deposit, A for arthritis, R for or renal in the form of hematuria or proteinuria. Hematuria or proteinuria. This is called palpable purpura. This is called inoxalant. P for palpable purpura plus one of the following: diffuse abdominal pain, IgA deposit, arthritis, and renal means you need to find out whether there is hematuria or protein. A male child presents to you with the swelling below the ear, but no systemic manifestation. There were two similar illnesses in the friends of the same village. So probably they must be talking about mumps. Okay, with swelling, probably mumps. What is the treatment for mumps? Give antipyretic and send them. Do not do IN because the inflammation will settle on its own. Image growth chart first line which increased at 12 years of age. What does the following growth chart represent? So increases at 12 years means we are possibly dealing with gonadal growth. Possibly dealing with gonadal growth. So what are all the features of sexual maturity rating scale? It is otherwise called as Tanner. Tanner means it contains 5 stages. Stage 2. Okay. Stage 2 is characterized by a testicular volume of more than 4 ml. Indicates that the boy has attained puberty. Precocious puberty means less than 8 years. Okay, delayed puberty means no secondary sexual cause. No. So first one is stage 2 is characteristic feature that the testis has enlarged of more than 4 ml. Okay, precocious puberty means thelarchy less than 8 years. Delayed puberty means no secondary sexual character by 14 years. Okay. Boys grows early compared to girls. Anencephaly is mainly due to failure of closure of anterior neuropore. So neural tube anterior posterior is Dandy-Walker syndrome, Arnold-Chiari malformation. Posterior. Anterior, you have encephalospe, porencephalus, holoprosencephalus, porencephalus. So anterior encephalocele, porencephaly, holoprosencephalus, polymicrogyria. A child, a 2-year-old child, fever, had a respiratory rate of 36 per minute and what is the diagnosis? Simple. Pneumonia management. You need to look for respiratory rate, chest in drawing, and then danger. So if respiratory rate alone is increased, it's called fast. If along with respiratory rate, chest indrawing is present, called chest indrawing. Finally, when you have danger sign, then it is called, okay, danger signs, chest indrawing pneumonia, right? These two are otherwise called as, these two are otherwise called as, or non-severe pneumonia. Non, so non-severe pneumonia is usually includes fast breathing pneumonia, drawing pneumonia. Okay. Whereas severe pneumonia is associated with the general severe pneumonia. Then you need to give you a course of AMP plus Gen. AMP at a rate of, okay, gentamicin 7. Fast breathing pneumonia, chest. What is the treatment for fast breathing and chest indrawing pneumonia? At 80 mg per kg. Okay. For what? Chest indrawing pneumonia. So here, so define tachypnea. Less than 2 months to, okay. So tachypnea means less than 2 months, more than 2 months, 1 year, 1 to 5 years, more than, okay. Tachypnea is here 2-year-old child, the respiratory rate should be more than that. So it is not at all a case of give only antipyretic, agent. A newborn with ambiguous genitalia and high 17-hydroxyprogesterone and DHA level. Which of the following is most probable enzyme deficiency? A newborn with ambiguous genitalia, 17-hydroxyprogesterone, DHA level. Which of the following is most probably enzyme deficient? In 21 alpha 11 17 with elevated DHAs, elevated dehydroepiandrosterone. It is probably a case of 17 alpha hydroxylase 17 alpha hydroxylase deficient. Which of the following is not in, okay, which of the following is not included in newborn care? So you can clean the baby and breastfeed, temperature regulation, but ear care is not, but it is usually eye. Okay, case scenario. There was a facial thymic and tetrol. Identify the syndrome. Hyjar syndrome is characterized catch entity is characterized by absence third and fourth pharyngeal. Third pharyngeal pouch leads to absent thymus. Leads to absent thymus. So what will happen? Recurrent infection. Then absent the thyroid. Absent thymus, parathyroid gland hypoglycemia. Then abnormal feces along with tetralogy of palate. Okay, with left lip bar is all about catch 22 deletion, otherwise George. Which of the following should be the best initial feeding method for a baby at 33 weeks? Less than 28 weeks, 28 to 30 weeks, 32, 34. Less than 28 weeks, IV fluids. 28 to 32 weeks, nasogastric feeding. 32 to 34, Pollard feeding. More than 34, direct. A neonate who was just born and found to have a heart rate of 20 per. So heart rate means 4 2. Irregular respiratory efforts. But there is that 4. A pink body with blue extremity. Pink body, blue extremity. 4 1. 4 1. And partially flexed limbs. Partially 4. And he showed grimace on stimulation by catheter. 4 1. So 1 4 4 plus. Correct answer for our score. The image shows a female baby with a rash on the face and perineal area. So it is zinc. Zinc is what? Acroderm. Reduced cell mediated in hypogonad. Hypogonad. Usually zinc 10 mg per kg. Acrodermatitis. A child had, next question, large head, large both large in size. Autism like fragile syndrome. DM syndrome is characterized by Travail aortic stenosis. Rett syndrome is characterized by girl neuroregression, acquired microcephaly, along with neuroregression. Eisenmenger syndrome arises as a result of left to right shunt chronically leading to pulmonary right to left leading to Okay. Eisenmenger syndrome means cyanosis goes, sorry, ECF goes cyanosis. A child is having different types of rashes all over the body. Cycle, measles, maculopapular, rubella unlikely in this case. Rubella post-auricular adenoma. Probably this one must be delayed, and we have been facing many cases of ulcer involving palm soles. What is otherwise called as palm soles and butter area? What hand foot caused by? And finally, all the following are components of tetralogy of Fallot. Tetralogy of Fallot is characterized by large EST, overriding aorta, right ventricular hypertrophy, and not tricuspid stenosis, pulmonary stenosis. Which one? Tetralogy of Fallot also characterized by boot-shaped, prone for cyanotic spell, which can be treated by oxygen, morphine, okay, knee chest position, oxygen, morphine, okay, and finally, time of discharge at propranolol and for BT or BT shunt. Okay, with this, we are finishing our topic revision today. Thanks a lot for